I want to thank you for coming out tonight. And I imagine there are going to be some people that are coming in over the next several minutes, so we'll bear with them. I want to stress that these conversations are open to people. Invite your friends, come on out. We have them once a month to talk about topics that relate to innovation and translation and sort of improving health for people. I want to stress that these have been brought to you in no small part by the Health Innovation Hub, which helps people commercialize on health matters, the Translational Research Program, but also Medical Innovation Toronto, which is a group that is a combination of 5 departments: medical imaging, medicine, pediatrics, psychiatry, and surgery from the Faculty of Medicine, and throughout a number of hospitals, including sick kids. And we have some really great people to talk to today. But to make this work best, let me say that this is supposed to be a conversation. A number of people, we heard ourselves. We want to hear from you, your opinions, your questions as well, and your responses to what's important for the future of health here and globally. So with that, I am going to introduce our amazing and wonderful moderator. We are very privileged to have with us Dr. Alan Kaplan, whose pleasure will be for the next 50 minutes or so to lead discussion. And then afterwards, once we've talked, it's an opportunity for all of you to network and get to know one another. So, Alan?
Thank you, Joseph. Welcome, everyone. So I'm just to give you 20-second information about myself. I'm the Vice Dean for Graduate and Academic Affairs in Medicine. I was previously the Director of IMS, and I helped to start the TRP. So that's my kind of legacy project and gives me legitimacy here. So just to get a sense of who you are, how many of you are graduate students? And other type of learner? Great. Any faculty here? Terrific. Visitors? Okay, so you're all welcome, and the only thing I'll ask you, as Joseph said, we want to have this a discussion rather than just us talking at you or with you. But the topic that we want to explore in this discussion has to do with the changing face of kind of healthcare. We're in a transition, and I would venture to say, and I'd be interested in what our panelists would say about what healthcare is going to look like in 10 years, 5 years, 10 years, 20 years. My sense is going to look very different. And the government has kind of shaking up the healthcare system in Ontario, really moving the provision of healthcare and resources from local LHINs to a more centralized entity, Healthcare Ontario. And maybe we can hear a little bit about the implications of that from the point of view of our panelists. So I'll read the kind of theme that this is supposed to take. So collaborative, integrative, multi-sectoral, interprofessional, value-based healthcare delivery models based on precision medicine. Are they the magic bullet that will save our healthcare system? And, you know, could this even occur in the comfort of your own home? The comment, somewhat provocative, is that care is moving from a centralized hospital structure to a decentralized community model. And one of the questions to explore is, how is this going to happen? How is this going to impact all of us? So with that, I'll ask our panelists to introduce themselves. Maybe we can start with you, Ronnie, and then ask each of them to comment to get the discussion going from their perspective about this whole issue. So, Ronnie?
Hi, I'm Ronnie Cohn. I'm a pediatrician and scientist who is interested in genome editing technologies and how this applies to neurological and genetic disorders, and I am also the CEO of the Hospital for Sick Children.
Hi, my name is Monica Kastner. I'm a research chair in knowledge translation and implementation at North York General Hospital, also affiliated with University of Toronto. I'm a health services researcher, but my passion is knowledge translation, both in terms of the science and practice of KT, and how do we get best evidence into practice and policy.
Hi, Gilbert Sharp. I don't know what I am, but I've done a lot of things. I teach health law and law and mental health here. I started out in medicine. I went into law. I wandered around, did some other things, but primarily spent a lot of years in government as legal director in the Ministry of Health, and morphed into private practice on Bay Street. And I'm currently special advisor to Minister Michael Tobolo, who's the Minister of Mental Health and Addictions.
Okay, so with that context, maybe I can ask each of you, from your perspective, to comment on this question. What is healthcare and healthcare delivery going to look like in 5 years or 10 years? Maybe we can get the conversation started by getting kind of your future vision. So, Gilbert, we'll start with you.
Lawyers look back at precedents. We have no idea. It's up to you doctors and scientists to tell us where we're going. I had an advisor years ago, a deputy minister named Martin Barkin. Some of you may remember Martin. A very wise fellow who said, well, here we are in government. We have two things we can use to try to move the health system: money and law. And we don't have any money left. This was in '88. So he says, it's up to you to write some stuff. So I wrote a lot of stuff. And I tried to capture from people like yourselves what the policy should be looking ahead, because writing laws, they tend to get stuck in sand, and it's very difficult to change. So we wrote something called the Regulated Health Professions Act. There's now 27 regulated professions here with their own regulatory bodies, colleges, and we expanded scopes of practice. We wrote something called the Independent Health Facility Act. Henry Morgenthaler had one in the Supreme Court of Canada, and the minister of the day wanted to find a way to fund his abortion clinics. And we coined the term facility fee and expanded it into diagnostics with the idea that it would expand around the province. My main focus has been mental health, particularly with young people and seniors, which is why I'm with Tobolo. We're trying to look at how we can move a system that's terribly in silos. We've got 16 government ministries, 16 departments that have a hand in mental health and addictions. And they have different laws, even with kids. The Child and Family Service Act with young people with mental illnesses up to 16, and then it switches to the Mental Health Act. So the consolidation of law is my interest, but I need to really hear from you, the policymakers, to tell us what we need to write.
Kind of a schizophrenic system from the sounds of it. What's your take on the future?
So it's a fantastic question, and we think about this all the time. My vision is really an integrated care model where we work together as partners with clinicians, patients, caregivers, families, more of an integrated way of looking at things, looking at context of the healthcare delivery. One of the biggest challenges that we have, I think, is, I'm sure a lot of you have heard of research waste, and this is still a pervasive problem that was identified back in, I think, 2009, and we're constantly working on it. And we were just chatting about this earlier, that on average, I'm sure some of you have heard the statistic that it takes on average about 17 years to get evidence into practice. And so one of the advantages of knowledge translation and implementation science is that you can shorten that period to 5 years, and we were saying that even that's too long. But with knowledge translation, you can make definite impact and change, which is really what we want. And we want to move away from that conceptual knowledge where we're changing perceptions into actual instrumental knowledge where we actually are using and applying the knowledge that we create. And that is what is needed to make decision-making both on a clinical as well as a policy level. So I think that's another big goal in a lot of the work that we do is to make things happen, to make the change happen. And one last point that I wanted to make is something that's often overlooked in health services research and knowledge translation is sustainability. And it's often one of the last things we think about, and it should be one of the first, because it doesn't matter how great an innovation or intervention is, but if it's not feasible or not sustainable, especially given our funding for the different programs and the way we want to deliver healthcare, that's one of the most crucial aspects. And a lot of people don't know that sustainability is a really important implementation outcome, and it's a very big part of knowledge translation and implementation science. So that's another big change that we want to make sure that we address that.
Ronnie, what's your vision? Maybe you can comment in the entire spectrum of age group, but for the youth in particular, which is the area you work in. How is it going to be different?
So I'm going to talk to you about my vision, which is called Precision Child Health. I also, though, think that it's a vision that is really true for the entire healthcare system. So let me take a few minutes to explain to you what this means. So if you look around the room right now and look to your neighbor, you will all be very proud to say that I'm different than this person and you are different than this other person. Now, in medicine, there's an interesting phenomenon that happens when you give a diagnosis to a patient or if you talk to a family of a child. Because the first question that the family is going to ask you, so tell me what's going to happen to my child. And then we as healthcare providers fall into this trap by beginning to cite certain percentages. So 50% are going to do this, 20% are going to do this. And we get really uncomfortable if our patients are not really fitting into what we call the middle of the Gauss curve. Not recognizing that the children who do different in any kind of shape or form, whether worse or sometimes even better than expected, are biological gems that are trying to tell us something. And we just need to start listening to this. So if you take that concept into mind, then there are really three pillars of a paradigm shift that leads to this concept. A, you have to move from the current analog data acquisition, which is kind of crude and still ancient, to a much more machine learning, AI-driven model of care. Everything we do in medicine right now is reactive. We are always reacting to the patients that are coming to us asking for help. And we very rarely think about prediction or preventative aspects of medicine outside of vaccinations. And then last but not least, we need to move from this one-size-fits-all approach to a truly individualized approach. Recognize that each single child and or patient or adult, even if they have the same disease, they're very different. So I give you three quick examples of what this looks like. These are all true examples, and then we can have a discussion about what you think about it. And if you're really interested, we can talk about something really ethically challenging that's happening right now in our hospital. But let's talk about three examples. Number one, if you think about precision, then a lot of precision has to do with diagnostics. So in May, when I was on service, on the floor, I had a child on my service who was born with seizures. At the time I came on service, she was 2.5 months old. And we treated like you treat every child who has seizures as a baby with one medication. There's always one medication you use. And we treated her, she didn't respond. And and we had to send genetic testing for her south of the border, unfortunately. It took like 6 weeks to come back. And it came back with a mutation in a gene that actually told us that we have to use a drug that you never ever use in a baby. You only use this in adult children. So we started the drug. 3 days later, she stopped seizing. So if you think this through, we actually have the technical abilities to do genome sequencing within 48 hours now. If we could have done that at our hospital, this child would have stopped seizing within a week. Would have started day 2 of life. Day 4 we would have a diagnosis. She would have stopped seizing. Second example is we had a few months ago 4 children on our cardiac unit who all were waiting for a transplant. Now they were so sick that they had an external heart that was really pumping for them. So it's like a heart in a bag. It's really cool, actually, if you think about it. Now, if you think about it, though, if you are connected to external material, all of these children are at risk for blood clots. And you treat all of these children with a specific medication that you always use for blood clots in children and adults if you had a heart attack. So one of the children clotted. The heart stopped working. We had to emergently put in a new one, like a new line to connect it. And we did pharmacogenetic testing on this child. So what is pharmacogenetics? So we all have our DNA, and in certain cases, our DNA tells us whether there are certain drugs we should or should not be taking, or we need to take more or less of it. So it turns out that this child had a mutation that allowed her not to metabolize this drug. So she should have been on aspirin. So the truth of the matter is, all 4 of these children had the same mutation. So we all put them on aspirin, so the other 3 didn't run into the problem of the clots. And the last example I give you is around prediction and artificial intelligence. So our pediatric intensive care unit team, over the last 5 years, has collected 7 trillion pieces of data on our children. If you take any kind of child in an ICU and count the amount of data that you collect per second, it equals the same amount of volume that water falls down the Niagara Falls. So it's a huge amount of data. And they collected these data and they developed an algorithm that predicts at 75% accuracy whether a child is going to have a cardiac arrest 5 minutes ahead of time. So what does that practically mean? Who has watched a Blue Coat on Grey's Anatomy? Have you watched this? Was that yes or no? I don't know. So you know what happens when you have a code in the hospital? Lots of activity. It takes at least 3 minutes until 15, 17 people are around the bed, and then you're going to get active. So either this algorithm is going to help us to be at least ready and have the team assembled and your crash cart and your medicine right there, or if you're lucky enough, you can prevent the cardiac arrest altogether. So these are just 3 vignettes to explain to you where I think this is going to go. I could speak about this for 2 hours, but I'm going to stop now.
Okay, so we have 3 very different views and visions of where healthcare is, what we need to do, and what are the essential components of transforming our healthcare system. One is precision medicine, one is the importance of knowledge translation, knowledge transfer, dissemination of evidence-based care, and we have a view from the legal framework. You know, do we need laws that will help us negotiate this new vision in our medical system? So maybe we'll open it up to questions. You've heard...
Truth of the matter is, you need the law and the knowledge translation and the ethics to bring this vision to life, because there's obviously a lot of complexities. And if you do this all in isolation, so knowledge translation is as much a piece of it as law is going to be a piece of how you're going to ensure equity and so on.
So my question specifically is about the preventative medicine. I think it's really great that sick kids can do this and has the resources to do this, but how do we go about implementing these preventative technologies in other healthcare settings, like in other hospitals or hospitals with less of an academic influence?
So first of all, we are just beginning to do this, so we're not doing it yet. We have just laid out the concept. But this is exactly where knowledge translation comes in. So as an academic health science center, we have a responsibility to figure out how to make this happen in a safe and efficient way. Once we have tested this and we feel comfortable that take these algorithms, there will be hundreds of these algorithms, they all have to be tested to make sure that they're safe and that they actually improve the outcome. But once you establish this as at an academic health system, that's your responsibility to make sure that everybody else can use it. So I think the biggest challenge of all of this will be for people to accept that they have to change certain practices that some of them have done maybe for 20, 30 years. That's the biggest challenge of this.
Do you want to comment, Molly?
Yeah, so that's exactly. So we're talking about figuring out the best evidence first, and then we think about how are we going to engage the organization, the specific units, what's the feasibility, what are the resources, how do we scale, how do we learn from an institution that has already done it, how do we ensure that even though it works in one setting, it may not work in another setting, so we have to figure that out. So there's context, there are the patients, there are the clinicians, the frontline, there's so many different variables that need to be considered, but the most important thing first is making sure that whatever it is that we develop is working the way we intended it to be working.
Yeah, so I was around government years ago when we faced the issue, talk about equity, you know, and this, we have to look at this as a province. We're lucky enough to live in Toronto and we have access to the great hospitals of the city, but what about people in Moosonee who look out the great problems Indigenous folks are having? So what we did years ago with cardiac surgery was set up a cardiac care network. And I think there were 17 cardiac centers and there's a triaging system. And then a few years after that with Cancer Care Ontario was established. It was supposed to have more of a controlling role than it did, but it's still playing a vital role. When we look at, I mentioned the 16 ministries, the challenge from a lawyer's perspective on driving integration is how to do that. I find it shocking that Sick Kids Hospital doesn't have a thriving genetics program so you can do the work there. And we have what's our health budget in Ontario? 63 billion? So the allocation of how
the ministry still doesn't want to pay for that testing.
Well,
we are working on this.
So this is, then who makes the choices and the calls and where they're made and what drives it? I spent 3 years on Health Quality Ontario on the board. It was very frustrating. And you know, the ultimate decision makers has always been a mystery to me, because the evidence that is forthcoming, that you see every day in your hospital, that you work on, that you folks, those of you physicians and others are looking at, that you deal with in psychiatry, that's the input that's required. So how do we translate that information into funds, into the necessary funds? I went a few weeks ago with the minister to see Stella's Place. I don't know if you know Stella's Place, but it's KMH helps run it. It's very impressive. And they need $1.5 million of operating to continue moving. The LHIN hasn't really funded them to the level they need, yet it's a drop-in center for kids 16 to 29. It's amazing the kind of things they're doing there, and it should be a model around the province. So how does one seize on these wonderful models that are there and say that there should be a provincial network for them? So in mental health and addictions, in some of the remote communities where suicides, we know what they are and we've seen the numbers and the examples, and these are things on the ground in the community. And is it just resources? Is it just money? How do we develop our senses of community in Toronto, it is a challenge. 3.5 million people, the sense of isolation. We met with the president of this university a couple of months ago, and he, very passionate, very caring individual, who said, you know, I'm putting counselors into our libraries and possibly in our residence and so on here. Where do we look for evidence, information, and responses and models, and then how do we implement them, and who ultimately makes the decisions on these very important factors, like having a thriving genetics program, so sick kids, a center of excellence for the country, really, should have this. You shouldn't have to wait 6 weeks. I'm preaching to the converted, obviously, but how do you get those resources? So need your help, need your input on this.
So I believe there's another question there.
So what are some of the major barriers to precision medicine, and how can we overcome these barriers to build interventions in this space?
So it might be a complicated answer. I'll make it easy for you. First of all, it's a cultural change. It's a change of thinking. So with all the fancy technology we're talking about, and that will require some investment in infrastructure of data and sequencing machines and so on, at the end of the day, it first starts with the appreciation of what I told you in the beginning. Recognize that this child in front of you is different than every other child, even if they're the same disease. And I tell you, I consider my goal for my first year in my new role that everybody in this hospital who keeps hear me talking about this all the time understands what I mean by this, and is going to begin to ask the question, why is this child not doing what I would expect this child is doing? And then you can talk about things like we need an infrastructure where we collect all the data. It needs to be all protected in terms of privacy. We obviously need a sequencer. We now have a sequencer that we got through a deal with a company, and our foundation is helping us with this, and eventually the ministry has to understand that we can actually do it for cheaper than the United States, believe it or not. Very few things in Canada are cheaper than in the US. Sequencing is. So, but I think it's a philosophical shift that has to first really be put into place before it happens. If you talk about precision medicine, most people always talk about genetics. It's far more than that. It's genetics, it's the combination of the environmental data, where did you grow up, social determinants of health, and combining all of this, that's really where you have to go.
I have a two-part question. So the first question is, I really appreciate precision medicine, personalized medicine.
Individualized medicine.
Individualized
Everything we do
medicine.
is personal.
It's, each patient is different. But the way it's, as healthcare practitioners and physicians, we communicate through notes is a horrible way of actually banking data, right? So a clinical note is completely useless in actually using machine learning to predict, to use data variables. And so as, you know, I'm from the University Health Network, and so as we're investing in a new EMR, likely Epic, which has been epically horrible in the United States, and in fact, Sick Kids is using. The question is,
You got our CIO to help you implement it.
So how are we investing millions in an EMR that has trouble classifying data so that we can actually perform precision medicine? Why are we investing so much money into something so archaic, where Google does a better job at looking at some of the predictors and coming up with differentials? Why are we going backwards in our EMR system if our goal is machine learning, precision medicine, personalized medicine, individualized medicine? That's question one. The second question is...
Just a comment about that. Yeah, we'll let the panelists respond to that first.
Okay.
But we did a survey And one of the strategic priorities of Faculty of Medicine is wellness, well-being, not just among students, but our faculty. And the single biggest factor that makes our faculty feel unwell is EMR, is the bureaucratic nightmare of trying to work with medical records, electronic medical records, but it's different in every hospital, virtually different in every hospital. I mean, you couldn't create a more chaotic system, and having to spend hours and hours documenting on a system that, you know, really is not very user-friendly. So that's direct evidence that what you're saying has real validity. So why don't we have the panelists, each of you respond to this question about the collection of personal health data, that we're using systems that are not user-friendly, and the term you used was archaic, and that they're not going to inform algorithms that's going to help us move forward with machine learning. I think that's the essence of what you're saying. So maybe, Gilbert, you want to take a shot at that?
Well, I'll tell you what really happened and why we're in this mess. I think it's been long enough, 20 years. So if you can picture 1999 and what was predicted to be a crisis with Y2K, the government was spending all its time, particularly the Ministry of Health, worrying about computers crashing at midnight. And we had been moving along a system where we had 60 of the top IT people in the country, from IBM, Bell, and others, working with us to develop a provincial IT system. We ultimately outsourced to something called Smart Systems for Health, an agency that we created to implement this. But there were, I won't go into detail because I think this is not appropriate, it's privileged, but I can tell you that they were hamstrung initially in their first year and were not able to properly work with hospitals in addition to the communities. And after the government changed and George Smitherman became minister, he was very frustrated at what you're sensing now and got rid of that agency and created eHealth. As we know, there were difficulties with eHealth as well over the years, and it never quite came together, so the hospitals were forced into the position of having to develop their own systems. And it could have been avoided. The vision was absolutely to do this in the 90s, to have one consistent system. They were looking at something made in Canada, made in Israel. We looked at a number of opportunities as to some very good systems that already existed. But now, arguably, it's too late. Look at the hundreds of millions of dollars that have been invested, and systems don't talk to each other. And I agree with you, you know, the electronic medical record problems. And then I had a hand in, we were trying to write privacy legislation, so we wrote the Health Information Protection of Privacy Act. There's federal privacy laws. Privacy commissions were set up. The commissioner was given jurisdiction over hospitals a number of years ago. And we all know how important privacy is in everyone's life, particularly with our patients. But we tried to make amendments to the legislation. We created a concept called the circle of care so that information could be shared within that without worrying about informed consent and age of consent and mature minors and appeals to review boards and so on. But it needs, I'm not sure what it needs, but certainly from a legal perspective, we need to clean this up. We need to provide enabling provisions to promote the ability to treat patients, particularly as we get more and more in psychiatry. Years ago out of McMaster, we started a program, a telehealth program with Penetang, where psychiatrists were able to do this, and we had an OHIP fee code to look after it. We set up the Ontario Telehealth Network. The fellow who first ran it is still there, which is wonderful. And that type of mechanism is our future, with secure lines to transmit data. But we need to break down the legal barriers. There are, at last count, 65 health statutes under the Ministry of Health. And there are many others against the 16 ministries that conflict. and we need to just create one structure and one system and one set of rules, so you're not always worrying about lawyers and protocols. Every hospital has in-house counsel. I know sick kids, I've dealt with your lawyers, very exceptionally fine. The hospitals pick the best and the brightest. KMH, I think, has 12. I do agree that my colleagues in law should have jobs, and no problem with them having jobs in the health sector, but a lawyer's job sometimes is to help implement, not to create barriers. Again, I'm going back to Dr. Martin Barkin, where one of my lawyers came in, he was asking how to do something, and this lawyer explained 8 reasons why it couldn't be done. And his comment yelling at this lawyer was, if the Reichmann's lawyers were here and they asked to do something and the lawyer gave that answer, they'd be fired. Well, civil servants can't be fired that easily, but we got the message. So sorry to go on, but
How does this issue affect effective knowledge translation and dissemination?
So I agree. I think this is one of the biggest tragedies that have happened, because I think I know we're trying to work towards a decentralized kind of way of thinking, but the one thing that has to be centralized is the way we collect and share data and information. And without that, it's going to be impossible for us to achieve that patient-centered and integrated care that we know has the best potential. So I think, like, it boggles my mind, even in Ontario, where you have hospital networks that use different systems, where family health teams that are affiliated with a particular hospital cannot talk to the hospital records, where they cannot share. I know in St. Mike's, I remember everybody was so happy when they're finally able to get data, like lab data, shared between the hospital and the family health teams. So I think this is a huge problem. I don't know what the solution is, but it has to be standardized. It has to be centralized for us to be able to utilize all that amazing data that we're collecting, and to be able to test it, and to be able to make this truly a patient-centered and integrated strategy. Yeah.
So the only thing I add, your comment is only partially true. Our machine learning scientists around University Avenue actually have mechanisms to extract much more out of these written notes, even out of writing things.
Standardized, right? So your template's going to be...
That depends on, no, many of them are, actually. Wait until you get Epic.
Maybe it's...
So this problem actually has been solved. I think that we at least try to get as much as possible out of this EMR, not to disregard any of these issues that we talked about. We do need the laws to help us to get access to data in a fairly different way than it is right now regulated. Right now it's really hard to access data under the current law, and there needs to be probably actually a federal approach to how we're going to access big data in a way that you don't obviously want to violate patients' rights. But if you actually ask patients, they want us to get access to their data so we can do something meaningful with them. It's fairly tricky from a law perspective, but needs to happen.
I just want to add one more comment, is that I think it's also really important what type of data we're collecting, because if we're going to move towards this precision individualized medicine, we do need the data that we're currently not very good at collecting, like lifestyle data, the environment, the history, the background. All of those things we're not doing a good job at collecting that data, and I think that will be a really important shift as well.
Other questions? Yes?
Yeah, that segues really nicely to my second question. And it's, machine learning is phenomenal in terms of the amount of data that we have, but the data that we have is full of bias. And so the question is how, without human involvement, and how do you systematically remove bias? So whether it's sex, whether it's race, ethnicity, provider bias? How do you remove that from your algorithms?
Not sure that you can entirely remove it altogether, but when our scientists are working on this, one of the first exercises, I'm not a machine learning scientist, but when I'm part of these discussions, one of the first set of discussions you always have is what's the bias associated with the question or the problem you're trying to solve, and then how can you work on an algorithm that's going to try to remove or turn down the noise of these biases as much as possible. I don't think you can ever get rid of it. At least our people say no.
Yeah, I was asking that. So right now we have the one size fits all. So you have a particular medicine for a particular problem. So let's say you have cough, and for cough you have a problem, and you prescribe a medicine that is actually tested with a placebo on multiple people, thousands of people, and you find out that yeah, this drug works. But for a disease or some personalized medicine, how would you test that this drug works? Because there's only one person. How would you see in future this personalized medicine?
Well, so right now it's all trial and error, right? So you take a certain drug that has been tested in X many patients, and if it's statistically significant, then you say that drug should be used. And then if you use it and it works, then you're happy. And then if it's not working, then you go down the spiral of, oh, let's try more of the drug, let's add on another drug, let's switch the drug. So part of the solution could be pharmacogenetic testing, like I gave you an example. But I think it all goes back to what we just heard here, that they should help us have so much information at hand to make the decision right away that this child may just never use or may never benefit from this drug for asthma, but may actually need right away this drug for asthma. That's where this is going to go.
So if I may just jump in, I think I know where you're coming from. I would beg to argue with you that we don't actually even have a one-size-fits-all healthcare system. We have a healthcare system or a drug-based system that is reversion to the norm, where the norm is specifically selected for clinical trials in order to allow you the best possible chance of passing through regulatory regimes. And so this new system is about your particular genotype and phenotype and how they come together and what possible ways you metabolize various drugs. So it's a very different approach than finding a medium and approving it and then trial and error afterwards.
There are also some, let's say, researchers at UofT that are looking at technologies to do testing with patient samples. So some labs, let's say, do organ on a chip. And so you can, in theory, take cells from a patient, you dose different drugs with these cells, and you see how those cells respond. And that's like another form of personalized treatment. Whether we get there is another story, but that's some avenues people are exploring.
Let's just please call this individualized. Everything you do as a healthcare provider is personal. I actually am quite serious about this. It's individual.
There's a question over there.
Yeah, thank you. So I'm really interested in this concept of sustainability. You touched upon it. I think it's critically important. And one thing we're really good at in Ontario is criticizing our healthcare system. Justifiably, but I think it's just chronic complaints. And my question to you is, when we look at things like knowledge dissemination, this idea of precision medicine, what jurisdiction would you look to draw, expertise from that would help inform our healthcare system? Because it is undergoing seismic shift right now, and I often would like to see the complaints are about our healthcare system complemented with solutions that are derived from other jurisdictional expertise. And I find that that's not happening right now. And I'm keen on learning more about where that may come from. Thank you.
Well, that's a really important question. I think that what we're not very good at is working together with the different sectors. We're not very good at knowing how to engage policymakers when it comes to research, when it comes to any kind of research, whether it's clinical research, health services research, whatever it is. I think that we work together with, for example, members of the ministry or any other federal, provincial policymakers, sort of indirectly or informally, and that process, there should be a formalized process for that. That doesn't currently exist. And I think because we do things in a different time frame, we speak a different language, our needs are aligned but different. The knowledge that you need for decision-making, policy decision-making, is very different than the knowledge that you need for clinical decision-making, but one will lead to the other. And so I think we have this new concept that I'm sure some of you have heard of this, the integrated knowledge translation, where we aim to work together with all of the different knowledge users that have an interest in the knowledge being produced, whether it's for decision-making, whether it's to gain knowledge, for whatever the reason, to work together for a common problem, to come to a common solution. And I think we need to have more of those voices around the table, and not just, because right now our funding structure is such that we are encouraged to do that, but a lot of it is very tokenistic. It's just like patient engagement, a lot of times is tokenistic. And so there's a science around integrated KT, and I think that will be the key for us to figure out how best to do that, especially towards these big problems that we're trying to solve. I'm not sure if I answered your question, but it's a very big question. I think this is all related to sustainability. And there's ways that you can assess sustainability, and it should be done at the beginning of a project, and it should be done with the people around the table that it will affect the most. So we know that much.
So that's a nice segue into a somewhat provocative question that I'll pose to all of you, which is, what do you think of the restructured healthcare system that the government has just implemented?
Brilliant idea, difficult to implement. I think it's a brilliant idea, and I hope we can implement it the way how it's supposed to pan out.
What do you see as the obstacles interfering with that working? For those of you, we're referring to a new central entity called Ontario Health, which is responsible for allocating resources across the province, which is a huge landmass with millions of people. So that's the challenge. And to be responsive to local needs, I think, is the other concern. So what's going to interfere with it working?
So personally, I think it's exactly it's the allocation of the resources. So you build these terrific networks of an Ontario Health team that really connect all levels of care and create this seamless integration of care for patients or families. And how you're going to allocate resources in a fair way, I think is going to be one of the biggest challenges around this. The tertiary care hospitals will play a different role in the whole system, and I think are going to serve all these. Here we just need to make sure that we as a tertiary care hospital are fully associated, if not integrated, in all these different OHTs so we can serve them and they can lean on us. It's probably less of a problem, but I think at the end of the day, unfortunately, it always comes back down to resources. And some of this is going to have to be associated with making things less complicated than Gilbert keeps talking about, meaning being more efficient. Being more efficient may need to reallocation of certain research. This is going to be the biggest problem. And they haven't even started to address it yet because it's so complex.
Yeah, and these healthcare teams are not disorder specific, nor are they age specific, right? Which creates even more of a challenge because that's the way we're used to delivering care. Do you have a comment, Gilbert, about this new entity and
Well, again,
vision?
having lived maybe too many years in the Ministry of Health, I saw a government in 1995 look to what was then the flavor of the month, regional health authorities, and we saw many provinces move to that. We didn't. The minister, having traveled to Alberta and other places, decided that it just wasn't something he could understand how it could work. My biggest concern is the failing of the LHINs, in my view, and the concept was good. The legislation was good. It gave them authority for their region. But the Ministry of Health, the minister centrally could not let go of certain things, negotiating with physicians, physician incomes, the OHIP budget, the independent health facility budget was kept central. And I think if you're going to be successful, and I'm not an advocate for regional authority, but I have known half my life Reuben Devlin, and I respect him highly, and he's one of the physician movers. He was CEO at Humber River, where they created a state-of-the-art IT hospital, a very gifted fellow who came up with others with this concept. Implementation requires what we've talked about today. Integration. Integration means the ability to share information within the regions. I think the Minister of Health has opened a couple of dozen of these already. I think she's traveled to each one. She wants to put her blessing on each region of the province that independently, it's very important to her. She herself championed 10 years ago a study on mental health when she was the health critic in opposition. So she has certain passions, and I worry about mental health and addictions getting lost in these large teams, because somebody once told me when I was asking for money to be provided for a certain outreach program. It was at Mount Sinai, and I think it was Joe Mappa, the former CEO, again, a very gifted administrator. And I said, why aren't we getting money for this psychogeriatric multicultural outreach program, which until then had been funded privately, but that money had run out? And he talked about mental health being the orphan of the health system, the difficulties and the challenges in that space. We heard you talk about very interestingly about the examples of the kids and the tests, and there was a test that identified aspirin or something else that helped them. Well, in mental health, we know how difficult it is. It's not fixing a broken leg. And sometimes with that frustration, that it's a bottomless pit of funding and support. So that's my worry, but I think the challenge is going to be, who's running? Matt Anderson's running, I think, Ontario Health, I believe, a very, very, very bright, experienced individual. And I hope he's given the tools to implement it. I think he will. This government has, from what I've seen, I've never worked politically. This is new for me. I've, been a career bureaucrat in my years in government, but it's given me access to things like, and I say this neutrally, I was quite surprised the other day that up until he became premier, Doug Ford was the Scott Mission giving out meals on Friday afternoon. I've seen another side, perhaps, and the passion and the legacy of wanting to do something. It's not just corridor medicine, we hear that all the time, but it's mental health, and it's a commitment to try to make things better. It sounds so corny to say, but I feel the stars are aligned now, and I'm not taking anything away from previous governments or health ministers or premiers, but I feel that we've got the right mechanism. But now can they pull the trigger in some very, very delicate areas and let go? To me, that's going to be critical.
Well, it's nice to have an optimistic view. That's kind of uplifting, I would say. Yeah. Did you want to comment on that?
Yeah, my only comment is that I think the communication mechanism will be key to making this work, and also community engagement, because I think that's where the LHINs failed, is that we didn't have enough of that link with the community that we were serving. So I think that's going to be the biggest challenge, the communication and the community engagement.
So we have a question over here. Sorry.
I was just wondering if the panelist has comment on what would be practical pathways to regulate AI. sort of in a very time-bound way within the healthcare setting?
Looking to the lawyer, who I thought you want. I thought you want to start first. Yes, I'm not a lawyer, but what I can tell you is we need to identify new ways of regulating this, because if you take an artificial intelligence developed algorithm and you walk it through what we have currently going on with devices or drugs like clinical trial structures, it's going to take about 150 years for all these algorithms to be tested. So we need to figure out a way how you can implement some of those in a safe manner, maybe under the umbrella of quality improvement and so on, and then really work together with people like Gilbert to make sure that you don't violate any kind of law, or that you create legislation in a way that supports this approach.
I think what we need is something that has been tried in other jurisdictions. It's called rolling legislation. What it is now, if we try to amend any statute in Ontario, it takes a long time. There has to be political will. The entire statute is open for debate. The opposition can make amendments. It's very complicated. But there's a concept of understanding when you write the legislation that AI is something that we don't know what it is. You have to look at the contexts and how it's going to be applied. And if you sit down with a pen and try to write law, the drafters, who are attorney general folks, it's an art of actually writing the words so that they can't be misinterpreted. I can go with the policy, and as a lawyer, I can write some things, but then their job is to pick just the precise words, which is sometimes why it's so hard to understand and read a statute, pick up the Income Tax Act. But to have a conceptual framework for legislation that demonstrates to society that the government is serious, it probably should be at the federal level with enabling provisions, opt-in provisions for the provinces to look at the penalties for improper application and to allow changes to be made as we go. There's a Uniform Law Commissioner group of all the provinces and territories that meet regularly to come up with model statutes. And there's a commitment that if they have the political will in their province, they will attempt to enact something that will be similar across the country. We did it years ago with the Human Tissue Gift Act, and there's other examples. We need that mechanism to move at the federal, provincial, territorial table, a commitment to prepare this, and as issues come along, to resolve it with changes to the legislation that can be done by a group without having to worry about waiting 10 years till the political will is there. It can be done if you have someone very creative with their finger on that button.
Just one last little comment, and I think that what will be the most important with regulation is patient safety and quality. I think that's where we have to be before we, as one of the important factors to consider.
This question over here.
So sort of on a similar line of thought, I was curious more in the context of the precision medicine and predictive algorithms, not necessarily like dynamic AI, but if we sort of consider today that, the 1999 of EMRs, how do you think we can prepare for or set up a system, or how do you see predictive algorithms being like either commercialized or disseminated following a model like drugs or medical devices that they're sold, or more like surgical procedures and techniques that are published and you can use without necessarily needing to buy or license, or more open access, I guess. I'm just curious if you see predictive algorithms falling into any of those categories, or if you think a new category or method of dissemination.
Yes, it's a good question. So first of all, there have been 150,000 publications about predictive algorithms or AI in medicine over the last 15 years. Guess how much has been implemented clinically? Give me a number. So 0.1%. The good thing about this, it can only get better. I really love this rolling legislation. I'm going to quote you in the future about this. So I think there are two aspects. You were asking about commercialization. It's very interesting that the community of scientists around AI is a very sharing community. They don't like to commercialize their algorithm, and it's probably a good idea because that's what they would add on to our healthcare costs and ruin or put pressure on our healthcare system even more so. But we just need to create a system that has quality and safety in mind, that allows it to implement these algorithms as a tool, similar to a stethoscope. It's not going to take over human function to a degree that you don't need to think anymore. It's just like a tool. But in order to use the tool, you have to test it, make sure that it's safe, and that the outcome is improved, and then you have to change the behavior of people. Have them be willing to accept that this algorithm can make me a better doctor rather than feeling threatened and being in competition with artificial intelligence.
This question over there.
I had a question for Ronnie. You had started the talk basically labeling your profession as something to do with genome editing. I was wondering what you meant by that, considering like the many ethical issues around genome editing today, and how you secure funding for something that could potentially not have too many large applications in actual human subjects.
Oh, so first of all, it's not my, so this is the kind of research that I'm personally interested in. Has everyone heard about CRISPR? Okay, so that's the kind of technology I'm talking about. So let's start with the last comment you made. Everything we do in my laboratory and in thousands of laboratories around the world, when it comes to developing treatments, and my passion for those are talking about human subjects that are born with a genetic disorder. So this whole issue of editing a human embryo is a completely different beast, and it's completely unacceptable. It's actually medically probably not even necessary to do so, given other technologies that we have. So that's number one. So getting research support for these kind of research studies is not a problem. Now, I do believe once we figure out how to do this in an efficient and safe way, it's going to revolutionize the way how we're going to practice medicine in 10 years probably from now. I think we will have a slew of genome editing gene therapies available at our disposal. And one of the most critical, important questions we're going to ask as a field over the next 20 years probably is what's the therapeutic window for some of these disorders? When is it too late to put a certain treatment in place? That would be a fascinating question that we'll have to figure out over the next decades.
So earlier we briefly talked about big data and the use of appropriate data collection with EMRs. So right now we definitely do collect this data, and it's in our routine daily care as physicians. A lot of this data is streamed into ICES. So I'll give you an example of Ontario Laboratory Information System. So all lab data that's collected in the province goes towards ICES, and it's all, it can be analyzed. The problem is that we know when people have abnormal data values, but the data is all de-identified right now as it stands. And in the most recent auditor general's report, there was a call, at least, and I'm speaking from my perspective as a kidney physician, about using some of this data, being able to use that to re-identify patients and in order to intervene on their care. So because we know who they are, we just don't have an identity associated with them without going through laws such as PHIPAA. And maybe, Gilbert, I'll get your opinion on this or your insights, and anyone else who would feel free to comment, about how we can work on what the Auditor General has asked of the Ontario Renal Network or other organizations on how we can use all of this data that we have available to us, how we can not get around, but to appreciate the role of PHIPAA and privacy and patient and why those laws were put into place, but at the same time be able to use that data in order to re-identify individuals, find out who's at high risk of progressing in disease or having our healthcare system as it currently stands fail them because they're not being followed closely or well enough, and how we can intervene from a legal perspective. How can we get the ball rolling?
That's an important question.
Well, I'm going to do as I've been doing so far this evening, because I'm a lot older than any of you, and give you an example from many years ago. So really date me. So I was inside the ministry, and we were working closely with the Faculty of Medicine here at UofT on different research projects. We had a very large research group at that time and enough money to fund projects. The epidemiologist here asked to fund a project that was testing cord blood on women for HIV. So this does go back a while, to determine whether it's skipped over and applied, could be transmitted and so on. So went through the Faculty Ethics Committee, the University Ethics Committee. A friend of mine, Bernie Dickens, who used to teach here at the law school, was on the committee, and they agreed to a protocol that it's a seroprevalence study, it would be anonymous, and patients would generally know about it, but they weren't going to ask consent. So part of the protocol was that obstetrician offices throughout Ontario would have brochures explaining that it was possible that that cord blood might be tested. 60% of babies born in Ontario in that year were tested, so it was a substantial size, and you needed to have that. And 11 cases were found of HIV positive. It went into the newspapers. There was an outcry that there should be a way of identifying those 11 in the public interest. Public health got involved, as you can imagine. And even Margot Somerville, a friend from the McGill Center of Ethics and Law, said that she was concerned that a battery had been committed on these women because they hadn't given informed consent. It became quite a cause célèbre at the time, and a study was done. This was the minister of the day, I think, was Evelyn Gigantis. I think she was the first NDP health minister. I think this was 1990. And she asked that a report be prepared and legislation be drafted to protect subjects of research in Ontario, that an Ontario board be structured to be basically an ethics board and so on. There are reasons politically why that never happened. But that kind of issue comes up from time to time. You deal with it now. There's a promise of anonymity. The ethics boards will, and the hospital ethics reviews will require or demand that. But if patients were aware of this, and you've made a very important point, that patients want data to be used to help. They don't want their own private information necessarily put out there that would be very embarrassing, but to be able to, there must be a way legally, and there should be, in the kind of evolution of legislation I'm talking about, to get maybe on admission or however the mechanism would be, and I would look at ethics committees to help guide this, but to get an approval, not necessarily a consent, to use information for certain designated purposes that would allow them to be re-identifiable in very special cases, and we could identify those cases in the regulations. So I understand what you're saying, and I've heard this frustration from many. And I think it's a challenge, but we should work together and try to do this. And there are many levels of ethics committees around the province now, as well as the government that has its own view, and agencies that would help and spend quite a bit of time on this. The universities, I think, could get together on something like this, to perhaps the medical schools to look at it. So it's a very important matter, and it should be addressed. And there are some, maybe the privacy commissioner would say there are never instances when you should be, having given the commitment of anonymity, you should be able to reverse that. But I don't like hard and fast rules, and I think we're looking at a greater public good, as long as individual privacy is protected.
Is there a legal way to solve this? If you look at the Canadian Healthcare Act that speaks about the benefits to an individual?
I think if you look at the federal act on privacy and the provincial act and the ability to make regulations, it may be that without it becoming a major legislative debate, that we could get agreement to do regulations that would address it. I think it should be examined.
So we'll take one more question. There's a mic.
Just a quick comment and question. First of all, the comment, Dr. Cohn, you had mentioned reminds me of type 1, type 2 errors. And knowledge translation would be tied into that. So people thinking, what is out of the norm? Could that be something clinically that needs to be addressed? As a clinician, we see that lots of times. Secondly, if I'm correct, you were at Johns Hopkins before you came to Sick Kids. And I'm actually curious, springboarding to the question that was about 3 previous. Johns Hopkins is very good, the university and the hospital, as far as integrating and getting things off the ground, getting funds. You were involved, if I'm correct, with Marfans and Dr. Cameron and all the other folks that are there. How do they get things off the ground? What can we learn from a place like that? Now, they have getting back to our implementation in clinics and community, Johns Hopkins is very good with their public health and getting out into the community and finding out what the needs of the folks are. And as you know, in Baltimore, there's a very diverse community, and it's very challenging to go out in the community and find out what the needs are in that community. So I'm gonna first ask you, question is, what can we learn from Johns Hopkins from your experience? What can we take from them, and what would be the way to springboard from that? Secondly, Monica, how would we integrate knowledge translation to that? And thirdly, from a legal perspective, obviously the laws in the States and in Maryland are different than Ontario and Canada. Thank you.
So I would argue that our ecosystem around University Avenue is at least as good as the one at Johns Hopkins, and the challenging community you have talked about in terms of diversity is full of problems still. I can tell you probably my most frustrating experience at Hopkins was that the divide between the poor African American community that really is in the neighborhood of Hopkins and the hospital was huge. And yes, there's a lot of research going on, and public health at Johns Hopkins is world leading, but I actually think our ecosystem here, when it comes to translating research, integrating it, is quite comparable. That would be my honest answer. And I'm not biased because I'm here now, because I was in both places. I loved it there, but we have an unbelievable environment here at University Avenue.
So we have it on people springboard to the other question. What can we take from there or other places and apply it to our great ecosystem that we have here? Is there anything? Or are we doing everything right?
So they're not doing everything right either. I think we're doing a lot of things right here. I don't know. It's probably not the kind of answer you wanted, but
I can comment on that.
Help me out, Alan.
Yeah, I mean, the potential for the healthcare ecosystem talk about GTA is enormous. We're too siloed, and we don't communicate and cooperate and collaborate across those silos, and I think that's a huge problem. And if we could ever get over that, TASN is the Toronto Academic Health Science Network, is working on this. So that represents most of the major all of the teaching hospitals in the city and some others as well, trying to break down some of those silos. I can give you many examples of that. So even in terms of having an ethics board that one hospital recognizes, and so that if somebody wants to do a clinical trial, and I've had this experience because I do clinical trials, doesn't have to go to 4 different ethics boards to get approval, which could take 6 months and delay the start of an important trial. So TASN has finally agreed, with the cooperation of Clinical Trials Ontario, to have a designated board of record in one of the hospitals that all the others would recognize. That's an example of cooperation and collaboration, but there's so many other examples of what we could be doing that would enhance our ecosystem. So that's just my own experience. I don't know if anyone else wants to comment.
Sure. First, I'm a big fan of Hopkins. I did some work years ago with a surgeon now retired named Walsh, who was, tough guy, but very interesting. And it's an area town that it's a little different in Baltimore, but I spent some time there and got to meet some of the clinicians, and very, very impressive. However, having said that, I was happy to come back to medicine in Toronto. The complex system of rules in the States, Medicare, Medicaid, HMOs, it's just rules and regulations everywhere. Totally different rules from one state to another. The federal rules are bizarre. Ours are complex, but I wouldn't look to the States for a model. I'd look to other Commonwealth countries, Australia, the UK, Sweden. There are some countries where I think we can see some very innovative models without the mess that the States has gotten itself into. Very fine medicine, very great surgeons and good thinkers down there, but not an example that I would go to. I think we can tweak things, we can tweak regulations here, we can work with people who are well-intentioned. I remember a few years ago some work done by TASN around having a uniform emergency record in Toronto, which has happened now. We can make some gains, and I think let's stay home and work with the folks we have here. They're pretty good.
Just one last comment about that. So I think in knowledge translation, I think we look to what works, and whether that's in the US, the UK, Australia, wherever it is, we know in certain clinical areas what each of those strengths are, and then we try and learn from it. And so I think part of the criticism of knowledge uptake is generalizability, and I think you talked about that. And generalizability is always in the forefront of what we're doing. It's kind of finding that right balance of finding the contextual factors that will determine uptake, while making sure that whatever evidence that we create can be adapted. So the way I usually think about it is, in any innovation, is coming up with a core set of qualities, values, factors that we know can be adapted somewhere else. And then that adaptation will involve other contextual factors that can be used to optimize that particular context. So that's how we think of that.
I mean, just to further comment, we are absolutely unique, and I've looked into this, maybe others have as well, but there is no other city that I'm aware of globally that has a metropolitan population of 6 million people with one medical school, one faculty of medicine. That is unheard of. It presents challenges, but it also presents incredible opportunities, and we haven't fully realized those opportunities.
And 262 languages spoken among the 6 million people. That's the other gold mine we have here.
We're a petri dish for the world. And with that, I'm just looking at the time, and I do want to leave a little bit of time for all of you to network with each other and with our panelists. So I want to thank Alan and our panelists for a great discussion. I feel bad about sort of calling it to an end, but it's warm, and we have about half an hour for all of you to sort of talk. So thank you for all the wonderful questions and engagement. And so at this stage, thank you very much. Please feel free to grab some more sandwiches and coffee, and for the next half an hour, network with each other and our panelists and ask some of the pressing questions you may not have had a chance to ask. Thank you very much for coming.